Uh, you would see that I'm again talking on epilepsy, and this is one of the very, very common topic. And in the last class, in which we spoke on how to differentiate a seizure from epilepsy, we discussed what is seizure, what is convulsion. Then we tried to see whether the event that is happening is actually a true seizure or whether it is a non-epileptic event which is there. If it is actually a seizure, whether it is a provoked seizure or an unprovoked seizure, and if it is a seizure, whether it is a focal or a generalized seizure. And we also discussed when to get an MRI, when to get a CT scan and EEG done, and what is the emergency management of first unprovoked seizure, and is it an epilepsy or is it not an epilepsy or not. So rather, these were the important points that I discussed. And today we will be basically discussing an overview of epilepsy in children, what are provoked seizures, how to choose the anti-epileptic drug, which anti-epileptic drug should be chosen, what are the recommendations for the choices of anti-epileptic drug, and how do you stop the anti-epileptic drug. So this is a very, very important topic that is pertaining to management of child with epilepsy. So we very clearly understand and remember that seizure is nothing but it is a transient alteration in the motor sensation or the consciousness due to an electrical discharge that is happening in the brain. So anything that is happening in the brain is a seizure. And if the child has more than two unprovoked seizures occurring at least 24 hours apart, we call this as an epilepsy. And if the child is basically fitting into a specific complex of the signs and symptoms that defines a unique epilepsy condition, then we call it as an epilepsy syndrome. For example, if the child presents to you with the typical absence and the EEG shows typical 3 hertz spike wave discharges which were there. So we call this as an epilepsy syndrome or childhood absence epilepsy. So it is very, very important to find out if you can fit the child into any kind of an epilepsy syndrome or not. Another term which we very commonly use what is called epileptic encephalopathy. So the another thing which we can basically see is epileptic encephalopathy, where you can see that whenever the epileptiform discharges, abnormality are themselves contributing to the epileptiform progressive dysfunction of the cerebrum, then you call it as epileptic encephalopathy. So at least I want all of you to remember that anything that is happening within the brain, that is electrical discharge that is happening in the brain, is a seizure. Anything that you witness in the child, that is the motor manifestation of the seizure, is what is called a convulsion. If the child is having more than two unprovoked seizure, we call this as an epilepsy. If there are certain specific signs and symptoms in a cluster, we call it as epilepsy syndrome, which is there. And these were the important things. So we define epilepsy as at least more than two unprovoked, two or more than two unprovoked seizures occurring at least 24 hours apart. So you very well remember from the first lecture that the provoking factors were, some of the provoking factors were head trauma, fever, right, hypocalcemia, hypoglycemia. So all of them were provoking factors. So if there were no provoked factors and if the child is having more than two unprovoked seizure, we call this as an epilepsy per se. Or in the first go itself, the child is basically having a diagnosis of an epilepsy syndrome, we call this as an epilepsy. So please try to understand that seizure is what is happening within the brain. Epilepsy is whenever the child is having a seizure, that means epileptiform discharges, more than two unprovoked seizures are happening, then you call it as an epilepsy. Now, what do you now very commonly you call it as an epileptic seizure? Epileptic seizure means the seizure can be epileptic or it can be non-epileptic. So that means if the seizure is happening more than two unprovoked episodes, then you call this as an epileptic kind of a seizure which is there. But if the epileptic, you can also have non-epileptic seizure. Like for example, simple febrile seizures are basically non-epileptic seizures. They don't convert into a long-term epilepsy per se. So epileptic seizures are nothing but it is a transient occurrence of the signs and symptoms due to abnormal excessive synchronous neuronal activity within the brain. Epileptic seizure is a very transient phenomena which has a typical onset and offset, which is of a very, very brief duration, and they can have certain clinical manifestations like sensory, motor, autonomic, and cognitive manifestation. So some of the important steps that we also discussed in the first lecture was regarding how we should take a detailed history and examination, try to determine whether the child has a seizure or not a seizure. If it is a seizure, is it an epileptic seizure or is it a provoked seizure? If it is an epileptic seizure, does it warrant an anti-epileptic drug? If you want to choose the anti-epileptic drug, which anti-epileptic drug will you choose? How to hike the anti-epileptic drug if the child develops another recurrence of the seizure? How long do I give anti-epileptic drug? How to stop the anti-epileptic drug? So these are some of the important questions that comes to our mind whenever we see any child with suspected seizures which are there. So the focus of the evaluation is, number one is to establish the seizure semiology. Please ask the parents to video record the event. जब भी बच्चे को दौरे पड़ते हैं तो उनको माँ बाप को बोलना है कि हमेशा फोन में प्लीज रिकॉर्ड करो ताकि हम भी देख पाए. And it is very, very important that video recording the event is very, very important, because half of the time you can make an impression whether it is a seizure or whether it is a non-epileptic event based on the video record itself. So many of the time the parents will say, हम तो भाई घबरा गए थे, हमने कोई video नहीं बनाया. But if that, always tell the parents that if the child develops another seizure, please record the video. So this is one of the very, very important instructions that we should always give it to the patient so that we are able to record what event is exactly happening. Now, once based on seeing the video, I can make out that whether it is a seizure or whether it is not a seizure. If it is a seizure, I can also make out that if the child is having aversion towards one side, only clonic jerk involving only one side of the body, then you know that you're probably dealing with a focal seizure, not a generalized seizure. So you can make out, this is what is called semiology. सेमियोलॉजी का मतलब होता है कि ये फोकल सीजर है कि जनरलाइज्ड सीजर है. ये हम वीडियो देख के या पेरेंट्स के डिस्क्रिप्शन से हम डेसिफर करने की कोशिश करते हैं whether it is a focal seizure or whether it is a generalized seizure. The next thing that you always make an attempt is that, can it fit into some syndrome? Can it fit into some syndrome? That means if the child presents to me with a absence seizure, I get an EEG. The EEG shows a typical 3 Hertz pattern. I know I have made a diagnosis of childhood absence epilepsy. So every time you see any patient with presence of seizure, please always ensure that try to make an attempt at a syndromic diagnosis. And this syndromic diagnosis is based on what is the seizure semiology and what are the EEG findings per se. So the example that I gave you was childhood absence epilepsy. Similarly, you can also have certain epilepsies which are basically benign Rolandic epilepsy, in which school going बच्चा 6 साल 7 साल का बच्चा typically मदर कहेगी कि नॉक्टर्नल सीजर्स होते हैं, बच्चा सोता है और आधे घंटे के अंदर अंदर उसको दौरा पड़ जाता है. और उस दौरे में मोस्ट ऑफ द टाइम द मदर विल टिपिकली से दैट कि वो ऐसा लगता है जैसे उल्टी करने वाला है, कुछ बोलने वाला है और वो बोल नहीं पाता और बेहोश हो जाता है. सो दे डोंट हैव टॉनिक क्लॉनिक जर्क्स, दे यूजुअली हैव गट्टुरल मैनिफेस्टेशन. गट्टुरल का मतलब आवाज निकलती है, गट्टुरल मैनिफेस्टेशन दे विल हैव. And when you get an EEG done for these children in a sleep EEG record, you typically get centrotemporal spikes. So that means if there is a nocturnal seizure in a school-going child, along with EEG showing a centrotemporal spike, you make a diagnosis of syndromic diagnosis of centrotemporal epilepsy or Rolandic epilepsy. So every time you see a child with a seizure, we always make an attempt that can it fit into some syndrome or not. Majority of the time you will realize that they don't fit into any particular syndrome, but you should always make an attempt to fit it into one kind of a syndrome. Then you determine the etiology and attempt the classification of the epilepsy into genetic epilepsy or structural epilepsy, metabolic or infective or inflammatory. So the etiology nowadays, as per the newer ILI classification, earlier it was called as symptomatic, cryptogenic, idiopathic. आजकल हम term use करते हैं genetic, structural, metabolic or infective, inflammatory etiology. So don't get scared with this figure. You're not expected to remember this figure, but only thing that I want to say is electroclinical syndrome. you use the word epilepsy syndromes to make a diagnosis based on electrical activity, that is EEG finding, and clinical activity, that is the clinical findings which are primarily there. So we always try to make out that if we can fit it into some kind of epilepsy syndrome. And one of the very common epilepsy syndrome that I have even shown you earlier is West syndrome, in which the child will typically have infantile spasms. Along with that, the EEG will show typical hips arrhythmia on the EEG. So you should be able to clearly make out, can you fit it into electrical syndrome? It also depends upon कि कौन सी उम्र पे शुरू हुआ. इन्फेंसी में शुरू हुआ तो ये वेस्ट सिंड्रोम हो सकता है. छोटे बच्चे में हुआ तो चाइल्डहुड एब्सेंस हो सकता है. अडल्ट में हुआ तो जुवेनाइल एब्सेंस, जुवेनाइल मायोक्लॉनिक एपिलेप्सी हो सकती है. So we always make an attempt to reach a syndromic diagnosis in epilepsy syndromes per se. So that means if a child presents to me with a seizure, the first step is initial stabilization, obtain an IV access. All children who present to you with seizure in emergency, always ensure that the blood sugar and calcium are always checked. That check the history, that is semiology, should be always checked. That try to find out whether it is an epileptic seizure or whether it is a non-epileptic seizure. The first thing that we tend to see is that कि कौन सी उम्र पे शुरू हुआ, जो दौरा पड़ा उससे पहले कहीं सर पे चोट तो नहीं लगी, उससे पहले कोई बुखार तो नहीं हुआ, उससे पहले कोई डायरियल इलनेस तो नहीं था. सो ट्राई टू फाइंड आउट इफ देयर आर सम प्रोवोकिंग फैक्टर्स और नॉट. फ्रीक्वेंसी ऑफ द सीजर, पहली बार ये दौरा पड़ा या बहुत बार पहले भी पड़ चुका है, इज इट द फर्स्ट एपिसोड और मल्टीपल एपिसोड्स हैव हैपेंड अर्लियर आल्सो. What were the preceding event? It is very important to find out that कि बच्चा क्या कर रहा था उस टाइम पे जब दौरा पड़ा था. Was the child awake? Was the child sleeping? Was the child playing? What was the child doing when the child developed a seizure? Always look at history of presence of aura which is present or not present, and then you try to focus on what exactly happened during the seizure. That is ictal manifestation, that is motor sensory manifestations which are there. After the seizure, what exactly happened, post-ictal periods which were there or not there. Does the semiology suggest some non-epileptic event rather than an epileptic seizure? You always make an attempt at the history which is there. So the algorithm, this I have already discussed with you, that how you should manage or see a child with epileptic seizure after you have taken the history. If the provoking factors are clearly present, treat the provoking factor. If there are no provoking factor, plan neuroimaging. If the child is sick, get a CT scan done. If the child is not very sick, please consider MRI to be done. If the CT or the MRI shows findings like NCC tuberculoma, treat that symptom. If the MRI is totally normal, then consider EEG. Then you should consider EEG. So these were some of the common provoking factors like head trauma, fever, dyselectrolytemia, hypocalcemia, hypomagnesemia, hypoglycemia. So these were some of the provoking important factors. इनको जानना इसलिए जरूरी है कि ये एपिलेप्सी नहीं होते हैं. इसका मतलब हाइपोग्लाइसीमिया को ठीक कर दोगे तो बच्चा ठीक हो गया, हाइपोकैल्सीमिया को ठीक कर दोगे तो सीजर भी ठीक हो गया. So they are not patients who go into epilepsy. So they are not patients who will require long-term anti-epileptic drug. So please try to understand that it is very, very important to understand that the provoking factors should be always recognized. Do not treat provoked seizures with anti-epileptic drugs per se. Okay, the important thing that many of the students often face is कि NCC को मैनेज कैसे करना है. जहां पे भी आपको बच्चा मिला कि दौरे पड़े थे, उसको दिमाग के अंदर कीड़ा आया है, तो कीड़ा गिनना है कि कितने कीड़े थे. तो if NCC, the number of the lesion is less than 5, always start. If the child has presented with seizure, always start the child with anti-epileptic drug. Get a Monto, get a chest X-ray done for the child to rule out tuberculosis. Always ensure that you get an eye evaluation done to look and rule out intraocular cysticercus which is there. Once the intraocular cysticercus is ruled out, then you start the child on oral dexamethasone in a dose of 0.15 mg per kg for a duration of 5 days. On the third day of dexamethasone, start albendazole. Albendazole is started in the dose of 15 mg per kg in 2 divided doses for a total duration of 28 days, and continue the steroids for the next 2 days. This is always important to understand that whenever you are starting albendazole, give it under the cover of the steroid. पहले हमने स्टेरॉइड इसलिए दिया कि कीड़े के बाहर जितनी सूजन है वो थोड़ी कम हो जाए, एंड स्टेरॉइड उसको एल्बेंडाजोल शुरू करने के बाद भी हम इसलिए कंटिन्यू करते हैं ताकि इफ द चाइल्ड डेवलप्स a reactionary edema, that edema will also be taken care of. So dexamethasone or steroids matlab albendazole should always be given under the cover of the dexamethasone only. The duration of albendazole is very controversial, whether you have to give it for 7 days or 28 days. So a lot of studies have shown that even 7 days of albendazole is as good 20 days albendazole. We change, but overall for the time purpose you can remember that it is 7 to 28 days. एक बार हमने एल्बेंडाजोल 28 दिन तक दे दिया तो 6 महीने के बाद नया सीटी स्कैन करके देखेंगे। अगर नए सीटी स्कैन में पूरा का पूरा लीजन गायब हो गया तो 1 महीने में दौरे की दवाई को बंद कर देंगे। बट इफ द repeat NCCT shows an active NCC, then repeat the course of albendazole. But if the repeat NCCT shows that it has become calcified, then if it becomes calcified, then only anti-epileptic drug needs to be given for a total duration of 2 years. There is no need to repeat a cysticidal therapy in such kind of children. Hope you're able to understand this particular important algorithm of how we should manage how you should be managing neurocysticercosis per se. Okay, now the next most important topic is basically in the provoked seizure is febrile seizure. This I have little bit covered, that febrile seizures are very common in children between ages of 6 months to 5 years of age. If the seizure that is happening विद द फीवर, मतलब बुखार चढ़ा और दौरे पड़े, और वो दौरे जनरलाइज्ड सीजर्स थे, दे लास्टेड फॉर लेस देन 15 मिनट्स एंड 24 घंटे में सिर्फ एक एपिसोड हुआ। अगर ये तीनों क्राइटेरिया फुलफिल हो जाती हैं तो इनको हम सिंपल फिब्राइल सीजर कहते हैं। बट इफ इट इज नॉट जनरलाइज्ड, इफ इट इज फोकल, or if the seizure is for a duration of more than 15 minutes, or there are multiple episodes that are happening in 24 hours, we call this as a complex febrile seizure. Okay, if it is a generalized seizure, if everything now out of the focality, prolonged duration and multiple episode, if the child is developing multiple episodes in 24 hours, we call this as a simple febrile seizure plus. सो बहुत बार क्या कहते हैं कि ये कॉम्प्लेक्स फिब्राइल सीजर में मल्टीपल एपिसोड्स इन 24 आवर्स को हम यूजुअली नहीं गिनते। वी यूजुअली टेक फोकैलिटी एंड प्रोलॉन्ग्ड ड्यूरेशन। एनी चाइल्ड विथ कॉम्प्लेक्स फिब्राइल सीजर हु हैज फोकल फिब्राइल सीजर और प्रोलॉन्ग्ड फिब्राइल सीजर should always be subjected to MRI brain to look for any evidence of mesial temporal sclerosis. Similarly, and febrile status epilepticus will always warrant long-term anti-epileptic drug. So please remember that long-term anti-epileptic drugs are not recommended in simple febrile seizure. They are recommended only in complex febrile seizure, and out of the complex febrile seizure also, it is only the focal febrile seizure and prolonged febrile seizure which requires anti-epileptic drug. So this prolonged febrile seizure is also called as febrile status epilepticus, and this febrile status epilepticus is very, very important to understand. That will always require MRI, will always require EEG and long-term anti-epileptic drugs. So remember that if I have to give anti-epileptic drug, the anti-epileptic drug that is most effective is valproate. Never give sodium channel blockers like phenytoin, carbamazepine to children with febrile status epilepticus or focal febrile seizure. It is very important that sodium channel blockers can often worsen the SCN1. It can block the sodium channel, due to which the seizures can worsen. So please remember that if you are considering to start long-term anti-epileptic drug, avoid giving phenytoin and carbamazepine to children with febrile status epilepticus. And now there is another important concept which is called intermittent prophylaxis. Intermittent prophylaxis का मतलब है कि हर बार बुखार चढ़े, हर बार हम 3 दिन का क्लोबाजाम दें। तो मतलब हर बार बुखार चढ़ के क्लोबाजाम दे तो हम इसलिए देते हैं ताकि उस बुखार में उसको बुखार के दौरे ना पड़े. So that's why it's called intermittent prophylaxis. So But Indian children are very, very prone to repeated infections. And you will see that हर घर में जिनके बच्चे होते हैं, तुम्हें पता है कि 6 महीने साल के अंदर कम से कम 5-6 बार तो उसको बुखार चढ़ता ही चढ़ता है बच्चे को. So that does not often warrant that every fever should be accompanied with clobazam prophylaxis. So give clobazam prophylaxis only if there are more than 3 episodes of simple febrile seizure in 6 months, more than 4 episodes of seizure in 12 months, or if the seizure is more than 15 minutes, or a seizure that requires medication, then only you will give intermittent prophylaxis with clobazam. Otherwise, you will not give intermittent prophylaxis. Please remember, there is absolutely no role of anti-epileptic drug. There is absolutely no role of anti-epileptic drug in simple febrile seizure. So never give anti-epileptic drug in simple febrile seizures which are there. Now coming to कि कौन सी दवाई हमें देनी है, तो जब हम epilepsy करके देखते हैं तो you will see that most of the children will be controlled on anti-epileptic drug, but 30 to 40% of the children are not controlled on anti-epileptic drug also. So the goal of anti-epileptic drug treatment is that we should try to achieve complete seizure freedom. दौरे की दवाई क्यों देते हैं? ताकि उसको वापस दौरे ना पड़े. एट द सेम टाइम उस दौरे के साइड इफेक्ट भी ना हो, कोई दवाई का कोई साइड इफेक्ट भी ना हो, and reduce the morbidity and mortality and improve the quality of the life also. So when not to treat with anti-epileptic drug, it is very, very important to understand that children with simple febrile seizure, seizures which are secondary to dyselectrolytemia, history which is clearly suggestive of a non-epileptic event, please do not start anti-epileptic drug. इसका मतलब अगर हाइपोकैल्सीमिक सीजर डॉक्यूमेंट हो गया तो कैल्शियम सप्लीमेंटेशन देना है, दौरे की दवाई नहीं देनी है. सो सीजर्स विच आर सेकेंडरी टू डिसेलेक्ट्रोलाइटेमिया, simple febrile seizures should not be treated with anti-epileptic drug. So it is very, very important to understand that history, if it is clearly suggestive of a non-epileptic event, मतलब अगर history से clearly पता चल रहा है कि ये breath holding spells थे, तो anti-epileptic drug उसको नहीं देना. So it is very, very important to understand that do not give anti-epileptic drug to all children with provoked seizures which are there. So you will require anti-epileptic drug if there is a history of epilepsy, if the child is already a GDD or a static insult or a head trauma that has happened, or if there is a focal seizure. मतलब पहला दौरा पड़ा और focal seizure था तो दौरे की दवाई देनी है. पहला दौरा पड़ा हेड ट्रॉमा के बाद दौरे की दवाई देने की जरूरत पड़ सकती है. पर अगर पहला दौरा पड़ा और बच्चे को ऑलरेडी ग्लोबल डेवलपमेंटल डिले था तो देन ऑल्सो यू विल रिक्वायर एंटी एपिलेप्टिक ड्रग. Or if there is some kind of a static insult or a brain insult that is already there और उस बच्चे में दौरा पड़ा तो anti-epileptic drug देने की जरूरत है. So it is very, very important to understand that all children with the first seizure should not be treated, but if it is a focal seizure or if the child has GDD, if the child has static or a progressive brain insult, then you will have to treat the child with anti-epileptic drug. Now, which anti-epileptic drug should I prefer will depend upon what is the seizure type. Have you reached any syndromic diagnosis? What is the age of the patient? Everything will totally determine that which anti-epileptic drug should you start. जब भी दौरे की दवाई शुरू करते हैं, we always start at low dose. It is very important to understand that we should always start the anti-epileptic drug in a low dose and we hike it to give me 1 minute. Okay, so it is important to remember that we should start at a low dose and hike it to maximum till the seizure control or the seizure side effect will develop. मतलब लो डोज से शुरू किया, ग्रेजुअली हमने हाइक किया. अगर दौरे रुक गए उस जगह तब तो सेम कंटिन्यू करना है एंटी एपिलेप्टिक ड्रग. But if the child develops a side effect to one anti-epileptic drug, either you think of an alternative drug or think of an additional anti-epileptic drug. But if you started one anti-epileptic drug and it is not effective even till the maximum dose, then only you should add the second anti-epileptic drug. For example, You started the child on sodium valproate and the child did not improve. You started at a low dose of 20 mg per kg. You hiked up to 40 to 60 mg per kg. The child still continues to have seizure. Then only you will consider adding second drug. Do not add second drug before reaching the maximum tolerable dose. I'm trying to repeat, maximum tolerable dose. मैक्सिमम टॉलरेबल डोज का मतलब होता है कि हो सकता है कि वैल्प्रोवेट एक बच्चा 60 तक झेल ले 60 mg पर केजी, हो सकता है दूसरा बच्चा 40 mg पर केजी के बाद ही उसके साइड इफेक्ट्स डेवलप हो जाए. सो यू विल नॉट गो अप टू 60 mg पर केजी, सो यू विल गो अप टू मैक्सिमम टॉलरेबल डोसेस ऑफ द right anti-epileptic drug. So this is very, very important. Suppose, for instance, if the child develops complete control on adding the second drug, तब तो फर्स्ट ड्रग को ग्रेजुअली विड्रॉ कर दो. पर अगर वो सेकेंड ड्रग्स ऐड करने के बाद पार्शियल रिस्पॉन्स, मतलब फर्स्ट ड्रग ऐड करने के बाद पार्शियल रिस्पॉन्स है, तो देन ऐड सेकेंड एंटी एपिलेप्टिक ड्रग एंड आफ्टर 2 to 3 months कंसिडर टेपरिंग द फर्स्ट एंटी एपिलेप्टिक ड्रग. So it is important to remember that we try to avoid polypharmacy. मतलब बहुत सारी दौरे की दवाई हम प्रेफर करते हैं कि ना दे बच्चे को. तो the drug that has not worked should go out. The drug that has worked should be used in maximum tolerable doses which are there. So the important concerns of polypharmacy that we need to take care is pharmacodynamic interactions which are very important. Risk of cumulative toxicity, मतलब अगर हम 4 दवाई 5 दवाई दौरे की देंगे तो it is important that we have a concern of polypharm, मतलब cumulative toxicity can also happen. Risk of idiosyncratic toxic reactions are also very, very important. So please be very careful that we avoid polypharmacy as much as possible. So there are certain drugs which act very, very well as far as choices of anti-epileptic drugs are concerned. So there are some good combinations like valproate topiramate is a very good combination. Valproate lamotrigine is a very good combination. Valproate with clonazepam clobazam is a very, very good combination. And at the same time, there are certain combinations which are absolutely useless. For example, phenytoin and carbamazepine. Can somebody tell me why phenytoin and carbamazepine should not be given together? Is there some problem that can happen if we give phenytoin and the carbamazepine together? You can type in the chat. Can you expect some problem that can happen? Phenytoin and carbamazepine. As far as phenytoin, yes, very good. One of the student has very, very clearly told that both of them are sodium channel blockers. So don't give anti-epileptic drugs which have the same mechanism of action. So it is important to understand that phenytoin, carbamazepine, both of them are sodium channel blockers. So no point in giving 2 anti-epileptic drugs with the same mechanism of the action. Always take care of the cost of the drug also. That remember that phenytoin, carbamazepine, phenobarbital are cheap medication. Drugs which are costly are levetiracetam, oxcarbamazepine. So don't prescribe drugs which are very, very costly, which patient you know that will not be able to purchase beyond 1 month, right? So please be very careful that if phenytoin is good enough choice, consider phenytoin, because एक बॉटल phenytoin की रफली 80 रुपए 100 रुपए की आती है जिसमें पूरे 2 महीने तक निकल जाती है, जबकि एक पत्ती ऑक्सकार्बामाज़ेपिन की 100 रुपए में 150 रुपए में खत्म हो जाती है. सो प्लीज बी वेरी सेंसिटिव व्हाइल यू आर प्रिस्क्राइबिंग मेडिकेशंस टू एंटी एपिलेप्टिक ड्रग्स आल्सो. Remember about drug interactions like clarithromycin, nifedipine, naproxen, rifampicin might alter the drug levels of anti-epileptic drug. So what are the drugs that you should never give? Remember that whenever you are suspecting a non-convulsive status epilepticus or epileptic encephalopathy, इसका मतलब बच्चा है वेस्ट सिंड्रोम का, लेनॉक्स जेस्टार्ट सिंड्रोम का, तो इन बच्चों में सोडियम चैनल ब्लॉकर्स लाइक कार्बामाज़ेपिन, ऑक्सकार्बामाज़ेपिन, फेनिटाइन, ये सारी की सारी चीजें अवॉइड करते हैं बिकॉज ऑल ऑफ देम आर सोडियम चैनल ब्लॉकर्स एंड दे विल वर्सन epileptic encephalopathy. Similarly, remember that in myoclonic seizures also you have to avoid carbamazepine, oxcarbamazepine and phenytoin. In children with suspected neurometabolic and mitochondrial etiology, avoid giving valproate as much as possible because you have a very high risk of hepatotoxicity. So jahan pe etiology of epilepsy is not clear, avoid giving valproate. Similarly, adolescent girl obesity, menstrual irregularity. So if a child who is, 14-year-old adolescent girl comes to you with epilepsy, I would prefer not to give valproate because they increase the chances of weight gain and menstrual irregularities, and they increase the predisposition to PCOD. So please be very careful that you avoid certain drugs in such a kind of a manner. So there are certain recommendations which are importantly available, but overall, I want you to remember that for focal seizure, carbamazepine, oxcarbamazepine, phenytoin are very, very good drugs. For generalized seizures, you will realize that all of them are good drug, but valproate is a very, very good drug. But in children with absence epilepsy, the only drug that is to be given is valproate or ethosuximide. Occasionally, you can give lamotrigine, but in children with myoclonic and absence epilepsy, never ever prescribe oxcarbamazepine, phenytoin, and carbamazepine because they will worsen absence epilepsy and myoclonic epilepsy. Similarly, in benign Rolandic epilepsy, you will see that carbamazepine and valproate are always the drug of choice. Similarly, in children with juvenile myoclonic epilepsy, valproate becomes the drug of choice and topiramate becomes the drug of choice. In children with absence epilepsy, I told you ethosuximide and valproate are good drug of choices. So remember that avoid giving phenytoin, carbamazepine to children with absence epilepsy and myoclonic kind of an epilepsy. So focal epilepsy के लिए carbamazepine is a good drug. New onset generalized seizure के लिए valproate is a good drug. But please remember, along with that, lamotrigine can also be given. But you have to remember that lamotrigine can worsen the myoclonic and absence seizure. If the child has absence seizure, you will see that ethosuximide and valproate are very good drug. If the child has infantile spasm, then steroids and vigabatrin are the drug of the choice, and the other drugs like carbamazepine, phenytoin should be totally avoided in children with infantile spasm. So you have to be very, very careful with these guidelines which are there, and you have to remember which drug to be given, which drug not to be given overall. So one important point that I wanted to stress, these are last few slides of mine. A very very important point is chrono preparation. Most of the time जो एंटी एपिलेप्टिक आती है वो क्रोनो या सस्टेन्ड रिलीज प्रिपरेशन में होती है. तो क्रोनो प्रिपरेशन का मतलब है कि क्रोनो प्रिपरेशन हम यूजुअली इसलिए देते हैं ताकि स्लो अब्जॉर्प्शन हो, स्लो ब्रेकडाउन हो. So it can be given up to twice a day. Ideally, the chrono preparation should never be broken. And if you are shifting from regular to chrono preparation, the dose needs to be hiked to 20%. The biggest problem with chrono is high cost of it. And similarly, when you're prescribing anti-epileptic drug with the syrup, always ensure that spoon से चम्मच नहीं लिखना कि एक चम्मच दिन में 2 बार. Always encourage the parents to use the syringe which is there and not to give it with a spoon or the cup, and try your level best not to keep changing the brand of the anti-epileptic drug. Always mention the strength of the syrup, because when it comes to phenytoin, syrup dilantin has 125 mg per 5 ml, whereas syrup peptoin has 30 mg per 5 ml. और दोनों के दोनों basically phenytoin होती है. So you have to be very very careful that the strength of the syrup should always be mentioned whenever you are trying to see. The important thing are 4 anti-epileptic drugs जो पहले ज़माने के traditional anti-epileptic थे. They are very very good drugs. Do not disregard those drugs. All of them have hepatic metabolism. Phenytoin and phenobarbital are very very cheap medications. They can be given in once a day dose. Valproate is a very very broad spectrum anti-epileptic drug. Phenobarbital का biggest concern is cognitive side effect. Phenytoin का मोस्ट इंपॉर्टेंट कंसर्न इज नॉन लीनियर काइनेटिक एंड टॉक्सिसिटी. तो अगर हल्का सा भी डोज बढ़ गया तो बच्चा झूमता हुआ तुम्हारे पास इमरजेंसी में आएगा. सो इट इज वेरी इंपॉर्टेंट दैट व्हेन इट कम्स टू phenytoin is very very prone to toxicity. Valproate has the biggest problem of weight gain, hair loss and tremors. Please remember, avoid prescribing valproate to adolescent girls for these concerns which are there. There are certain newer anti-epileptic drugs. I just want you to remember few anti-epileptic drugs if it is possible, especially lacosamide, zonisamide, topiramate. They are very, very good drugs for focal seizures which are not responding to conventional anti-epileptic drug. There is a drug called stiripentol which is useful in one of the epileptic encephalopathy called Dravet syndrome. Similarly, topiramate is something which is again useful in Lennox-Gastaut syndrome, which is there. There are certain important other focal drugs like brivaracetam, perampanel, eslicarbamazepine and retigabine, which are very good for refractory focal seizure. So even if you're able to remember one or few newer anti-epileptic drug, it is a very good choice which is there. So to just to sum up, focal seizure, carbamazepine, phenytoin, levetiracetam, zonisamide is a very good drug. Generalized seizure, absent seizure, myoclonic seizure, valproate is a very good drug. Based on epilepsy syndrome, if it is a West syndrome, you know ACTH and vigabatrin are the drug of choice. In children with Lennox-Gastaut syndrome, valproate, lamotrigine is a very good choice. In children with juvenile myoclonic epilepsy, valproate and clonazepam are very, very good drugs. If the child presents to you with hepatic failure and the child throws a seizure, you know that you have to avoid phenytoin, carbamazepine, valproate, everything. So the only drug that can be given is levetiracetam. So levetiracetam is safe in hepatic failure, which is there. This you all remember that which anti-epileptic drug overall acts, but I just want all of you to remember that phenytoin, carbamazepine are sodium channel blockers and they should be avoided in absence and in myoclonic kind of epilepsy. And this I have already covered. But two things that I don't want all of you to miss is that कि कोई भी छोटा बच्चा जिसमें conventional anti-epileptic drug काम नहीं आ रही, please think of pyridoxine responsive seizure. So a simple tablet like pyridoxine can work really wonderful, right? So remember that apart from anti-epileptic drug, there are certain drugs that is very, very important. Pyridoxine should always be given. If you're suspecting biotinidase deficiency, you might have to give biotin. Similarly, if you're suspecting cerebral folate deficiency, folinic acid can be given. So any small infant with refractory seizures not responding to conventional anti-epileptic drug should always be given a trial of pyridoxine, folinic acid, and biotin. Right? So it's a very, very important point that I want to understand, make you understand. The last thing that I want all of you to remember, it is not only anti-epileptic drug. आज के दिन में surgical is very, very important. तो मतलब अगर hippocampal sclerosis है या focal cortical dysplasia है, तो जहां पे focal abnormality होती है, epilepsy surgery is a very effective medication. So don't give 5 anti-epileptic drugs. Send them to a person who is able to do epilepsy surgery for these patients. So it is important to remember that surgical management of epilepsy is a upcoming thing, and you should recognize candidates who are very, very good for this thing. So finally, जब दौरे की दवाई बंद करने की बात आती है, हम यूजुअली 2 साल तक इंतजार करते हैं. जब 2 साल हो जाता है तो अगला जो दवाई को बंद करना होता है वो यूजुअली वी स्टॉप इट ओवर 3 to 6 months duration. So please mind that you don't stop anti-epileptic drug very, very fast. It should be always slowly tapered off. EEG should always be performed prior to anti-epileptic drug. If the EEG is abnormal, then the chances of recurrence are very, very high. So please remember that anti-epileptic drug needs to be withdrawn slowly over a duration of 3 to 6 months rather than abruptly withdrawing. You should always advise recovery position for a child whenever. तो जो भी मरीज सीजर का आता है, roll the child, tell the parents to roll the child to one side with the face supported by the child. The lower hand and the leg are to be kept straight. The upper knee is to be bent at the right angle. So this is what is called recovery position. और ये recovery position seizure करके अगर आप YouTube में देखोगे तो बहुत सारे तुम्हें वीडियोस मिलेंगे. So always ensure that जिसको भी मिर्गी का दौरा हो तो हर मरीज के माँ बाप को ये recovery position जरूर बतानी है. Similarly, abortive medications are also very important. Abortive medications में one of the commonest medication that we prescribe is intranasal midazolam. It is given in the dose of 0.2 mg per kg. The rough dose that you can remember is that कि हर 10 किलो में 4 पफ देते हैं. तो 10 किलो का बच्चा है तो 2 पफ in each nostril. 30 किलो का बच्चा है तो 6 पफ in each nostril. 50 किलो का बच्चा है तो 10 पफ in each nostril. 70 किलो का बच्चा है तब भी 10 पफ in each nostril. So the maximum dose is 20 puff, that is 10 puff in each nostrils which are there. So the final slide is that you should remember that when to start anti-epileptic drug, that is unprovoked epileptic seizures in children need to be started on anti-epileptic drug. Choice of anti-epileptic drug will depend upon कि दौरा टाइप क्या था, क्योंकि हमें पता है कि एब्सेंस है तो हम वैल्प्रोवेट या इटोसक्सेमाइड देंगे. एपिलेप्सी सिंड्रोम क्या था, तो वेस्ट सिंड्रोम है तो हमें पता है कि ACTH स्टेरॉइड्स या विगाबैट्रिन देना है. It also depends upon what are the other underlying conditions which are there. Duration of anti-epileptic drug is very important depending upon the etiology of the seizure. Minimum of 2 years of seizure-free interval should always be kept. anti-epileptic drug should always be withdrawn over 3 to 6 months with an advice for domiciliary management. So thank you for patient listening. If you have any